Every red blood cell in the human body follows a strict terminal trajectory. It begins in the bone marrow, where a stem cell extrudes its nucleus to become a functional erythrocyte, ending 120 days later, engulfed within the sinusoids of the spleen. Normal erythropoiesis is an exact, measurable balance between that marrow production and this peripheral clearance. Diagnosing red cell disorders requires abandoning the habit of looking at isolated metrics like the mean corpuscular volume, or MCV. Instead, it demands the integration of the complete blood count, the reticulocyte response, and the peripheral smear. This diagram maps out the master anemia framework. It is a cascading algorithmic decision tree that begins exclusively from one starting point, a confirmed low hemoglobin reading. From here, the diagnostic logic branches downward into distinct morphological and mechanistic pathways. Hematological mastery requires spatial, algorithmic deduction. It is about understanding how these variables interact, rather than simply memorizing standard reference ranges. Before applying any part of this framework, there is a mandatory first step. You must confirm the low hemoglobin reading is genuine. A sudden drop in hemoglobin might be a real disease, or it could be a spurious artifact. Common interference includes IV fluid dilution, pregnancy-related hemodilution, or cold agglutinins clumping the cells. Once the anemia is confirmed, the framework relies on a dual classification system. It interweaves the physical size of the cells, the morphological classification via MCV, with the functional state of the marrow, the mechanistic classification of production versus destruction. Skipping this initial confirmation step and failing to identify laboratory artifacts renders the entire algorithmic tree structurally useless. When MCV drops below 80 femtoliters, we enter the microcytic anemia branch. Iron deficiency pairs high RDW with low ferritin. Thalassemia contrasts this with low MCV but normal ferritin. Finally, chronic inflammation features elevated hepcidin blocking iron, causing normal or high ferritin. The final microcytic node is the sideroblastic pattern, defined by unique biochemical markers like high serum iron and morphologic markers on the smear, specifically ring sideroblasts. This creates a major clinical pitfall for this branch. A high ferritin level in the presence of systemic inflammation absolutely does not rule out underlying iron deficiency. In normocytic anemia, the absolute reticulocyte count is the mechanistic pivot. An inadequate response under 2 indicates production failure, like in chronic kidney disease, where Ret-E drops. A regenerative response over 2 points to peripheral destruction or acute blood loss. The reticulocyte count acts as the ultimate polygraph test for the bone marrow. It instantly reveals whether the marrow is actively compensating for a peripheral attack or failing at the source. Following that regenerative response branch leads us into the dedicated hemolysis algorithm. Hemolysis requires a biochemical tetrad: high LDH, high indirect bilirubin, dropping haptoglobin, and high reticulocytes. The DAT filter then divides this into immune and non-immune causes, where specific smear shapes like spherocytes or schistocytes map to definitive diagnoses. While high reticulocytes and anemia guarantee there is a destruction problem, only the combination of the DAT and the smear can pinpoint the specific mechanism of that destruction. The final morphological branch is macrocytic anemia, triggered when the MCV exceeds 100 femtoliters. This illustration demonstrates how to distinguish the 2 main macrocytic paths. On the left, the megaloblastic path features distinct macroovulocytes paired with hypersegmented neutrophils. On the right, the non-megaloblastic path, often caused by alcohol, liver disease, or MDS, shows round macrocytes without that hypersegmentation. To separate B12 from folate deficiency, we look at the biochemistry. While both deficiencies elevate homocysteine, only a B12 deficiency will also elevate methylmalonic acid. This specific deficiency harbors a dangerous clinical trap, B12 pseudo-TTP. Severe B12 deficiency can cause intense ineffective erythropoiesis, producing schistocytes and extremely high LDH levels that perfectly mimic true thrombotic thrombocytopenic purpura. You differentiate B12 pseudo-TTP by checking the reticulocyte response and the cell size. The B12 patient will have a low reticulocyte response and a high MCV, whereas true TTP drives a strong regenerative response. Confusing B12 pseudo-TMA with true TTP leads to disastrous clinical mismanagement. It proves exactly why the reticulocyte context is paramount over isolated findings like schistocytes on a smear. When all major cell lines fail simultaneously, we enter the overarching pancytopenia algorithm. The established reticulocyte rule still applies here. Low reticulocytes dictate a marrow production failure, whereas high reticulocytes suggest peripheral destruction or sequestration, such as hypersplenism. When peripheral testing cannot resolve the diagnosis, you may need a bone marrow biopsy, but the criteria for ordering one are remarkably strict. It is reserved for cases of unexplained pancytopenia, dysplastic smears, or a suspected leukoerythroblastic infiltration. This comparison shows the two distinct diagnostic utilities of a bone marrow biopsy. On the left, the cellular smear of an aspirate is best for evaluating individual cell morphology and iron stores. On the right, the solid architectural tissue core of a Trephine biopsy is necessary to assess overall marrow cellularity and fibrosis. The cardinal rule of marrow biopsies is that you never perform one for a straightforward iron or B12 deficiency. It is strictly a tool of last resort for unresolved algorithmic failures. The ultimate test of this clinical framework is coherence. A single diagnosis must perfectly explain the hemoglobin, the MCV, the RDW, the reticulocytes, and the peripheral smear without any contradictions. But clinical reality is often messy, presenting as mixed pathology where the data contradicts itself. For example, a perfectly normal MCV might be hiding a massively elevated RDW. This happens in dimorphic anemia. Concurrent iron and B12 deficiencies pull cell sizes in opposite directions. The microcytes and macrocytes average each other out, collapsing into a deceptive, false normocytic reading. Another major contradiction occurs when clear biochemical markers of hemolysis present alongside a near-zero reticulocyte count. This specific hemolysis reticulocytopenia paradox always indicates a secondary marrow failure overriding the hemolytic response. A classic example is a parvovirus infection, halting red cell production during a sickle cell crisis. This brings us to the central operational rule of the entire framework. If the absolute reticulocyte response does not fit the proposed diagnosis, the diagnosis is inherently wrong or incomplete. True diagnostic mastery lies not in confirming expected patterns, but in rigorously investigating internally inconsistent data. You must always trust the integrated algorithm over any isolated lab value.